Hello, my dear future nursing officers. Welcome you all to the Master Nursing classes. So, in this today's particular video, we are going to discuss again the very important questions and concept for our upcoming Norcet exam. So, here I am giving the best shot and the last shot on the OBG. So, some important tables, some important classifications, some important grades, some important scales we have discussing here along with some important drugs in the OBG. So this particular class may go somewhat lengthy. I want every one of you to stay connected till the end because this is a very important class and this is the last class on the OBG. Okay, so after this we will hit the other subject. Okay, so again in the form of the rapid revision. So there I will try to focus only on those very important questions. Okay, so here because this is the major subject and this is your rank deciding subject in the mains. Okay, so that is the reason I have discussed the OBG in detail in perfect along with the golden point revision. Okay, including the minor points also I have covered in the OBG subject. Okay, so the next we will cover a very important and high yield only, right? So this is the last class I am telling, and here I am going to hit all the only and only important portion and the only and only that is a necessary portion for your exams, right? So without wasting the time, we will start the today's session. A very good evening to one and all. Good evening, very good evening to one and all. So if any one of you are new to the master nursing classes, please do subscribe to the channel, and all are live to the session now. Please hit the like button. Yes, fatapat do hit the like button. We will start with the class. Better. So I want every one of you to keep in your mind that yes, you are here to get the All India rank number 1. So don't say in front of me that if I am getting one job means that is the enough, sir, wherever it may be. Don't say that one because you are preparing good, you are preparing well. Okay, so don't say that wherever in the India I am getting means okay. So you have to say that I will get the good rank in this particular upcoming exam, sir, and I will get a seat where I want, and I will get the seat where is my first preference, right? So this is a mindset you have to keep in your mind. So that is the reason I am telling, think big, trust on yourself and make it happen because it is in your hand now, right? So no one can say that if I am getting the one job anywhere in the India, it is okay, sir. Why? Because you are preparing, bro. So that is the reason, right? So you are preparing means you have to say you have the right to say that I will get the job here I required and the job that is near to my home and the job in my comfort place. So this should be our mindset. When you will get that particular thing, when you will target for the All India rank number 1. Okay. So if you are saying if I am getting any rank, I am getting anywhere means there is a chance to get select, but you are saying that I will get the All India rank number 1, there is 100% chance to get select, right? So with this powerful motivational quote, I am starting the today's session for you all. Okay, so please completely be involved in the session, and whether the answer may goes wrong or right, so please keep on commenting your answer in the comment box because it engages your mind in the class. Okay, so here is the first question in front of you all. So please do read the question carefully, completely, and try to give the best answer in the comment box. Yes, the question is very simple and very important. Which of the following is the most common cause of the primary postpartum hemorrhage? Yes, the options are retained product of conception. Option B, uterine atony. Option C, genital tract trauma. Option D is the coagulation disorder. The question is very simple. I want everybody's answer in the comment box now. Yes. A very good evening, beta. Very good evening. Welcome you all once again to the master nursing classes. So please do read the question completely and give the best answer in the comment box. Yes, almost all you people have given the correct answer. So that is the atonia of the uterus goes to the correct answer for this question. This is the most common cause of the primary PPH, or we can say the primary postpartum hemorrhage. So let me revise all the golden points on the primary postpartum hemorrhage. Beta, what is the normal blood loss after the normal vaginal delivery? Yes, how much is the, we will consider the normal loss of the blood in the after normal vaginal delivery. Fatapat do mention your answer in the comment box. Normal blood loss after the normal vaginal delivery is up to 500 ml. Okay, so up to 500 ml is the normal blood loss we will consider. If it is going more than 500 ml in the normal vaginal delivery, so that is, I will call that one as on the postpartum hemorrhage. So what is the normal blood loss after the LSCS or the cesarean section? Yes, how much amount of the blood we can say it is a normally lost blood in the LSCS? Fatapat do mention your answer. Well done, beta. So that is the 1000 ml of the blood is getting lost, means in the LSCS we will consider 1000 ml of the blood loss is the normal blood loss. If in normal vaginal delivery the blood loss is more than 500 ml, and in LSCS case the blood loss is going more than 1000 ml, so I call this one as in the postpartum hemorrhage. So what I call this one? I will call this one as in the postpartum hemorrhage. Very, very important. Keep in your mind. And the postpartum hemorrhage is the hemorrhage which happening immediately after the birth and up till the 12 week. Okay, up till 12 weeks, right? So hope all the golden points are clear to every one of you. And here we have the types of the PPH. So that one is the primary PPH, means the postpartum hemorrhage which is happening within first 24 hours. So this is what I call as the primary PPH. Okay, so most common cause for the primary PPH is the autonomy of the uterus. Autonomy of uterus. And here is the secondary PPH. Secondary PPH happens from the after 24 hours to till 12 weeks after delivery. Okay, so here the most common cause of the secondary PPH is the retained placental tissue. Retained placental tissue. Very, very important. Keep in your mind what is the meaning of the retained placental tissue. Here, the complete placenta have not come out of the uterus. Still, so part of the placental tissue is inside the uterus only. So uterus is unable to contract properly. So the bleeding will happen. Okay, secondary PPH means after the 24 hours up till the 12 weeks, the bleeding is happening pervaginally after the birth of the mother. So this is called as the secondary PPH. And here the most common cause is the retained placenta. And the primary PPH means after the delivery within 24 hours of the birth. So there is the heavy bleeding happening pervaginally in the mother. So that is the most common cause is the autonomy of the uterus, means the uterus have low tone. Low tone means low contraction. Low contraction means high bleeding. Okay, so that is the very, very important golden points you have to keep in your mind, right? So hope the concept is clear regarding the types of the PPH and the golden points on the PPH. So here is the next question. So that is on the 4 T's of the cause of the PPH. So please do mention your correct answer in the comment box. Fatafat. The 4 T's of the cause of the postpartum hemorrhage includes all except option A, tone, option B, trauma, option B, thrombosis, option D, tissue. So which one is not considered as a 4T? Okay, so in the question they have mentioned except. So be careful, students. So here this is not a time to make the mistake. Okay, this is the time to prove yourself, right? So just while attempting the any questions in your prelims and in your mains, so please do focus on the special words like except and no, not included, first priority, last priority, next immediate management, best nursing management. Okay, so these are very important words you have to keep in your mind while reading the questions. Okay, so that one you have to hold in the mind and start to read the question options, and automatically you will get the correct answer. Okay, so the answer goes to this particular question is the yes beta, if the thrombosis is happening or the increased clotting is happening, means bleeding will decreases. So here it is not a cause of the postpartum hemorrhage. Okay, so understand this particular 4 T's of the postpartum hemorrhage. Here the first T stands here as the tone. Tone is decreasing. Okay, so tone is decreasing means the PPH will increases. So that is the autonomy of the uterus will be the very, very important thing. So this is the most common cause. Okay, overall most common cause we can say or the most common cause in the primary PPH also, we can say that is the atonia of the uterus or the decreased tone of the uterus. Okay, so then comes to the trauma. So trauma means while the normal vaginal delivery, if there is the tear or the breakage in the perineum is happening, means that is what we call the perineal tear. So because of the tear in the perineum also there will be a bleeding will happens. So that is also a cause of the postpartum hemorrhage, right? So the next one is the tissue. If the any placental tissue which is retaining inside the uterus and the complete placenta have not come out of the uterus, still some part of the placenta is still inside the uterus, so that is what we call the retained placenta. So that is also increases the risk of the bleeding, and the retained placenta is the most common cause of secondary PPH. Secondary postpartum hemorrhage means PPH happening after 24 hours within 12 weeks. Okay, so that is what we call as the secondary PPH. Okay, so the most common cause for the secondary PPH is the tissue, that is the retained placental tissue, right? So option like last T was is the decrease the thromboplastin. If the thromboplastin is decreased, means the ability of the clotting also will decreases. Ability of the clotting also decreasing means there is the increased risk of the bleeding. Okay, so if thrombosis means there is increased clotting will be there. Okay, if increased clotting means bleeding will decreases, so it will be not in a 40. Okay, so the 40 stands here the T, tone, decreased tone, bleeding, trauma, perineal tear, bleeding increases, and the thromboplastin deficiency, that again the bleeding increases. Okay, so the last one is the retained placental tissue, that is also bleeding will increases. Okay, so hope it is clear to every one of you. And here is the next question. So within next first 10 to 15 minutes I will cover all the PPH, because this is the concept with a fixed question in your exams. Okay, yes, the question is in front of you all, so please do mention the correct answer in the comment box for it. Yes, so without wasting a minute of the time, we will cover the entire syllabus which is remained in your OBG in the today's session. Okay, so please do read the question carefully. Yes, which maternal factor is associated with the higher risk of the PPH? Option A, maternal age of the 20 to 25 years, means she is a young age mother. Okay, so there is no any risk of the PPH because her uterus will be a fully strengthable, and her perineal muscles are having the full strength, and she is having the ability to contract perfectly. So this is not in the factor which is associated with the PPH. Okay, normal BMI will not associated with PPH. There is chance of happening of the PPH in the obese mothers. Okay, so not in the normal BMI. So then comes to the option C, polyhydramnios, means the amniotic fluid which is more in the uterine cavity. Okay, so in the amniotic fluid index, where the which is more than 25, and single largest pocket volume which is more than 8 centimeter. Okay, where this very important. And the what is the amniotic fluid level here? Amniotic fluid which is more than 2 liter. Okay, so this is the where we can say the polyhydramnios. Okay, so the amniotic fluid is overloaded. That time the uterus also big uterus. Okay, so uterus also big here. So big uterus which will bleeds more. Remember the trick, big uterus which is bleeds more, right? So here the big uterus is there, so that is having the ability to bleed more. So this particular polyhydramnios is the a maternal risk factor which will increase the risk of the postpartum hemorrhage. Okay, so normal hemoglobin level will not increase the risk of the postpartum hemorrhage, but anemia and pregnancy. Anemia and pregnancy, it increases the risk of the PPH. Okay, so which increases the risk of the PPH, very important. And anemia in pregnancy is the most common indirect cause of the maternal death, because it is an secondarily contributing for the increasing the risk and incidence of the postpartum hemorrhage. Okay, so remember the a very important point on this one. Okay, so immediately in the anemic patients in the pregnancy only, we will try to correct the very important all the deficit hemoglobin levels by giving the folic acid and the iron in the early pregnancy. Okay, so that is the very, very important. In the early pregnancy, first 4 weeks we will give for the prevention of the neural tube defect. Okay, after the 4 weeks, where we are giving the folic acid plus iron. Okay, initially in the first 4 weeks of the pregnancy, just we will give the a very important folic acid, right? So that is for the purpose of the prevention of the neural tube defect. After the 4 week, where we are giving the iron plus folic acid, so that is for the prevention of the our anemia in the pregnancy. Okay, so that's the very, very important. Here the maternal risk factor of the postpartum hemorrhage. But remember, if the mother is having the antepartum hemorrhage, she is having the highest risk of the postpartum hemorrhage. Remember, very important point. Okay, so next, if the mother is having the pregnancy induced hypertension, so she is having the highest risk of the PPH. Remember, if the mother is a case of the gestational diabetes mellitus, here the fetus will pass the more urine. Okay, so the polyhydramnios will happens. Polyhydramnios will happens. So because of this, the mother will be having the highest risk of the PPH. In the polyhydramnios, there is the big uterus. Big uterus bleeds more. Okay, so very, very important thing. Keep in your mind. And in the obese mother, she will also having the risk of the PPH. And very, very importantly, keep in your mind, a mother with anemia. Okay, anemia in pregnancy, so definitely it will increases the risk of PPH. Okay, it will increase the risk of PPH. So these are the very important risk factor which is related to the mother. Okay, so which is having the highest risk of the causing the PPH. Okay, so along with this, so there is the over distended uterus, like over distended uterus. So in the over distended uterus, what we can say here, the uterus is completely or overly distended. If in case of the twins baby, okay, if in case of the twins baby, means inside the uterus 2 babies are there, that time the uterus will be over distended. Or again, in case of the polyhydramnios, again the uterus will be over distended. Okay, so in case of the macrosomic baby, where the baby's weight is more than 4 kg. Okay, so twin baby or the macrosomic baby, so where the distension of the uterus will be more, so there is an increased risk of the bleeding will be there. So please do keep this all the important, because it will help you to eliminate the option. Okay, so this is the important, because I am teaching the PPH by holding the important all the points, because the PPH is the very, very important thing, right? So the next factors which contribute for the PPH during the labor process. Okay, so if the labor is delayed, okay, delayed labor increases the risk of the PPH. And the precipitated labor, also increases the risk of the PPH. So what is the precipitated labor, sir? I will explain, don't worry about that one. Okay, so otherwise excessive oxytocin use during the process of the labor, you are using the excessive oxytocin, which will causes the resistance to the oxytocin. Okay, so if you are overusing the oxytocin during the process of the labor, there will be a resistance to the oxytocin, means oxytocin will stop to work. Okay, so that time there is oxytocin not working, uterus is not contracting, bleeding will increase. Okay, so excessive oxytocin which will causes the resistance to oxytocin. Okay, which will causes the resistance to oxytocin, and which is also increases the risk of the our very, very important postpartum hemorrhage, the risk which are related to the labor factors. Okay, so I told what is the precipitated labor. Yes, what is the precipitated labor? Precipitated labor is the entire labor process, which is completing within 3 hours. Okay, within 3 hours. So this is what you call the precipitated labor. Here also it increases the risk of the postpartum hemorrhage. So what is the precipitated labor? Precipitated labor is the labor have been started, labor progressed, labor completed within the 3 hours. Okay, so that is what we call the precipitated labor. Okay, so then the placental factors which increase the risk of the postpartum hemorrhage. Okay, so if there is in the placenta retention, if the placenta retention means the placental tissue is still inside the uterus and which is not coming outside. Okay, so that is the placenta retention we can say, or the placental anomalies where the bilobed placenta. So those placenta which will like one lobe will come out, another lobe will again which will retain inside the uterus. So that is the placental retention again we can say. Okay, so along with that there is a maladherement of the placenta will be there. Okay, so that is the maladhered placenta. What it means, sir? Yes, there are the term where we will study three terms. One is placenta accreta, placenta percreta, another one is the placenta increta. Beta, so remember, this is the uterus. Okay, so and inside the uterus, here this red color, the thing what you are able to see, this one is the muscle inside the uterus. So we call this one as the myometrium. Okay, so here whatever the light blue color you are seeing here, so this is the endometrium of the our uterus. Okay, so this is the innermost layer of the uterus is the endometrium, middlemost layer of the uterus is the myometrium, and the outermost layer of the uterus is the perimetrium. Okay, so usually placenta should attach to the our endometrium layer. Okay, so that is still the decidospongiosum, it will get attached, right? If in case this particular placenta, it is attaching to the myometrium. Okay, so placenta attached to the myometrium is the placenta accreta. Attached accreta, remember. Okay, and if particular placenta which is gone inside the myometrium, just attached superficial is the accreta, which is gone inside the myometrium is the increta. Okay, so remember, placenta attached to the myometrium is the placenta accreta. Placenta which is entered inside the myometrium, that is the inside the myometrium is entering placenta increta. Okay, very important. And one more word, where the placenta, it will crosses the myometrium and it will enter still the perimetrium. So that is what you call the placenta percreta. Till the perimetrium it gone, or the which is crossed the like myometrium, so that is the placenta percreta. So these all are three types of the maladhered placenta. In this one also, if the placenta will not comes easily, the uterus will not come contract properly, so there is highest chance of the postpartum hemorrhage is there in the all three maladhered placenta. Okay, so mal means abnormal, adhered means attachment, adhere means attaching the placenta. Okay, so abnormally attached placenta we can say, just attached to the myometrium accreta, inside the myometrium which entered increta, which crossed the myometrium, that is the percreta, which entered till the perimetrium, that is the percreta. Hope it is clear to every one of you. Yes. So let's come to the point of discussion. That is our multiple choice question here in front of you. So please do read the question carefully, then try to get the best answer. Right. The question is here in front of you all. So what is the first step in the management of the primary postpartum hemorrhage due to the uterine atony? So uterus is atonic here. So that is the uterus is not contracting properly. So what is the first step of the management in the primary PPH? Okay. Yes, I want everybody's answer in the comment box. Fadafat. So we will finish this particular management of the PPH very soon. Okay. So fadafat, do mention your answer in the comment box. Yes. What is the first step in the management of the primary postpartum hemorrhage due to the uterine atony? Beta, option E, perform the laparotomy. So it is studying to open the abdomen. Is this possible to open the abdomen for just because of the PPH as the first management? No, beta. First management is not to open the laparotomy, like not to open the abdomen. Option B is to administer the tranexamic acid. So we will give the tranexamic acid, but it is not first priority. So first priority is, yes, almost all you have given the correct answer. First we have to massage the uterus. Okay, if you get the uterus soft, boggy, so then the uterus is not contracting properly. That time you have to try to massage the uterus, so it will start to contract. Uterus is contracting means the risk of the PPH will decrease. So that is the reason the first step in the management of the primary postpartum hemorrhage is always and always. So that is the uterine massage. Okay, so very important. And blood transfusion also not first priority. So here is the steps. whenever the mother comes with a postpartum hemorrhage or mother will experiencing the postpartum hemorrhage, means the normal vaginal delivery bleeding is happening more than 500 ml, LSS bleeding is happening more than 1000 ml. So in that particular time the bleeding have been happened. Okay, so initially we have to resuscitate the patient. So how we have to resuscitate? First, we will do the uterine massage. One nurse will do the uterine massage and another nursing officer. So she will do the non-specific management. So what is the non-specific management? We will establish the two large bore IV cannula. Okay, so two IV cannula. So that is the large bore IV cannula we will start, and we will give the IV fluid. So that is the ringer lactate or the normal saline should be given, and dextrose should not be given in this particular situation. Okay, so don't give the dextrose, only give the RL and the normal saline. Okay, so along with this we have to send for the blood grouping and the cross matching we have to send, and we need to arrange the blood. Okay, so arrange the blood for immediate blood transfusion if necessary. Okay, so first thing in the non-specific, two large bore IV cannula I will give. Okay, so then the RL and NS I will transfuse, and the blood grouping and cross matching I will send. Okay, so very importantly, so then I will arrange for the blood and I will keep for the necessary emergency management. Okay, so specifically how we have to manage the PPH. From here, the multiple time questions have been asked. Okay, so from here, the question have been asked multiple time. So we will do all the important golden point chanting on the management of this particular specific management of the PPH. Okay, so first thing we have to do is the first and best thing we have to do is the, if the uterus we are feeling this is the soft bogey and the non-contracting, so that time we have to start the uterine massage. Okay, so uterine massage we have done. If it is not controlling the bleeding, means I will start to give the medication. So that is the WHO recommended best drug to treat the PPH and to prevent the PPH. That is our oxytocin, the 40 international unit. Beta, there I have told that is the 10 international unit. Where I had told the 10 international unit? In the active management of the third stage of the labor, I had told the 10 international unit of the oxytocin in the normal saline or in the RL, and don't give in the dextrose. Okay, so that thing I have told during the active management of the third stage of the labor. So here in the PPH, we will give the 40 international unit of the oxytocin again in a 1 point of the NS or in the RL. Okay, and I will start to transfuse that one. That is the medical management. If from the first line drugs, from the oxytocin, the bleeding is not controlling, means I will go for the second line drugs. Okay, so in that one, I will go for the methamphetamine, symptometrin, or the prostaglandin analogs like carboprost, misoprost. To that I will go. Okay, so I will explain the medical management in detail, because from the drugs the question have been arised multiple time. Okay, so first I will do the uterine massage and I will go for the medical management. Still I have done all the first line treatment drugs I have given, second line treatment drugs I have given, still the bleeding is not controlling. So after the medical management, just we have to wait for the 30 minutes. Okay, within the 30 minutes bleeding not controlling, means I will go for the mechanical management. Means manually I will create the pressure on the uterus. Means how I will create the pressure. One hand I will give on the like I will press from the per abdomen, and another hand I will push inside the vaginal cavity, and I will push the uterus in between my hands. So that is the bimanual compression of the uterus. Otherwise I will take the Bakri balloon catheter, or otherwise I will take the Sangas-taken Blackmore tube, and I will insert the uterus, and I will fill with the 300 to 500 ml of fluid, and I will create the pressure on the uterus, so the uterus bleeding may get decreases. Okay, so that is the what we call the mechanical management. Just I am giving the overview. In detail we will discuss. Okay, so even after creating the mechanical management, means in the bimanual compression also bleeding not controlling, Bakri balloon, Sangas-taken Blackmore tube we have implanted, still the bleeding is not controlling, means I will go for the surgical management, where if the family is completed, I will remove the uterus. So that is the hysterectomy I will do. If the family is not completed, means that time I will do some surgical management like a B-Lynch suture. So the last time your prelims and in our mains exams, so there was one question on the image based question of the uterus suturing. So that is the B-Lynch suture. So that one also we will discuss in detail. Okay, so after mechanical management, still the bleeding is not controlling, means I will go for the surgical management. Okay, so hope it is clear to every one of you, right? So here the uterine massage I have done, and I have done the medical management. Okay, so in the medical management I told what we will do. So first line drug, remember this one, first line drug, that is the oxytocin. Sir, how much I am giving, sir? Sir, I am giving here the 40 international unit in RL or normal saline. And remember, don't give with dextrose. If you are giving the oxytocin with the dextrose, it will increase the risk of the water intoxication. Okay, sir, how I will give, sir? I will give this one by IV infusion. Okay, so I will give this one by the IV infusion. Never ever give the oxytocin directly IV bolus. If you are giving the oxytocin directly IV bolus, means it will cause the two dangerous side effect. One is two dangerous side effect. One is there is a severe sudden hypotension, and another one is the cardiac failure. So remember, or we can say cardiac arrest, not failure. So it is in the cardiac arrest. Okay, so very important. Just keep in your mind these two side effects. Okay, so that is the reason oxytocin should not be and never ever be given directly IV push, or the IV bolus should not be given. Okay, so always try to give the oxytocin by the IV infusion and give with this one in the ringer lactate or in the normal saline. Okay, so don't give with the dextrose, because dextrose increases the risk of the oxytocin induced water intoxication. Okay, so hope the concept is clear. So this is the first line drug. Still the bleeding is not controlling, means, so I will go for the very important second line drugs. In the second line drugs, what are the things I will give? We will give the methyl ergometrin, that is the methergin. Methergin we can give, or we can give the symptometrin. So that is the combination of the oxytocin and methergin, that is the symptometrin. Okay, so, or I can use the prostaglandin analogs. Prostaglandin analogs. Okay, so very importantly, we have to keep in your mind, right? So here is the next question which will arise from you all, in front of you all, in the exams on the prostaglandin analogs. So do read the question carefully, completely, and try to mention your particular answer in the comment box. So please do read the question. Which of the following prostaglandin is not used in the management of the postpartum hemorrhage? In the PPH management, we are not using the one prostaglandin. So which prostaglandin is that? Option is the carboprost, that is the prostaglandin F2 alpha. Beta, this carboprost, it will cause the uterine contraction. It will cause the uterine contraction only. Okay, so that is the reason I will use this one in the management of the PPH. Okay, so I can use this one in the active management of the third stage of the labor also. I can use this one. Okay, but I will not use this one in the induction of the labor, because to induce the labor, so drug should have the capability to make the cervix softening. So the drug should have the ability to ripening of the cervix, then only I can use that one in the induction of the labor. But the carboprost is not having any effect on the cervix. So carboprost is only and only which is having the effect on the uterus, and it will contract the uterus. So I will use the carboprost only in the PPH, means the postpartum hemorrhage control, and in the treatment of the active management of the third stage of the labor, I will use the carboprost. And this misoprost, what we are studying, or the prostaglandin even what we are studying here, so this is, it is having the both effect on the uterine contraction also and the cervical ripening also. So that is the reason this particular misoprostol, so we can use in the treatment and prevention of the PPH also, and we can use this one in the active management of the third stage of the labor also. Okay, so, and we can use this one in the very important medical termination pregnancy also. We can use the misoprostol, or that is the prostaglandin E1. Okay, so then comes to the dinoprostone. So dinoprostone is the our prostaglandin E2. Okay, so don't confuse carboprost, misoprost, and dinoprost. One more drug will come. Okay, so the dinoprost is the another name of the so that is the dinoprost is the another name of the our prostaglandin F2 alpha. So we can call carboprost also, and we can call that one as in the dinoprost also, or we can call that one as the hemabet also. Okay, right? So this is the dinoprost only. So this is the dinoprost 1. So then dinoprost 1 is the, that is our prostaglandin E2. So this is having only action on the cervix. Okay, so it will only do the cervical ripening. So that this one, the dinoprostone, I can use in the induction of labor, not in the PPH or not in the active management of the third stage of the labor, and I can't use this one in the MTP also. Okay, so very important, the best drug in the induction of the labor is the dinoprostone we can use. Okay, so very importantly keep in your mind. So in the question, what they have asked, which of the following prostaglandin is not used in the management of the PPH? Beta, carboprost, that is the or the dinoprost or the hamabet, that is contracting the uterus. So I am using that one in the PPH. And the misoprostol, that is the prostaglandin E1. So it will contract the uterus also, and it will like do the cervical ripening also. So I am using this one in the PPH. So this carboprost also will be used in the PPH, and the misoprost also will be used in the PPH, and dinoproston only will be used in the induction of the labor, and this will not be used in the management of the PPH. In the question they have asked which prostaglandin is not used in the PPH management. So that is the dinoprost 1 is not used in the PPH management, okay, or the prostaglandin E2 is not used in the PPH management. So this is the very important questions that may ask from the drugs which is managing for the very important our what we can say PPH management of the medical management. Okay, so here is the next question. Okay, so before going to the next question, just I am revising your thing. That is the what we have done here. We have done the uterine muscles, still the bleeding have been not controlled. So I am doing the medical management. In the medical management, oxytocin, the dose, everything we have studied. Then comes to the secondary drugs we have studied. That is the misoprost we can give like mifepristone, sorry, not misoprost, carboprost. Okay, so we can give along with that the methergin as a secondary drug we can give. Okay, still after doing the medical management, we have waited for the 30 minutes. Still the bleeding is not controlling, means I will go for the mechanical management. Okay, so just I will try to push the uterus by using the catheters, tubes, and the by hands also. Okay, so here is the question in front of you all. Okay, so the question is here in front of you. Which of the following is the mechanical method used to control the postpartum hemorrhage? Yes. Option A, that is the oxytocin infusion. Option B is the uterine artery ligation. Option C is the Buckley balloon catheter, and option D is the tranexamic acid administration. But this tranexamic acid is also comes under the medication management. Okay, so this is the non-specific drugs. We will use this one in the all the situations where the bleeding will happen. Okay, so this particular injection tranexamic acid, or we can say that injection tranexa, or in the hospital settings, we will use to call this one by with lots of love. The tranexa will be called as in the injection pause. So why we will call this one as the pause? Pause means so to stop. Okay, so consider if the doctor is doing some debridectomy. Okay, so some like dressing procedures where there is the risk of the bleeding is there. Okay, so in order to control the bleeding, we will use the pause. Okay, so doctor will say to you, so load the pause, give the pause. Okay, so that is the pause means injection tranexamic acid, which will stop the bleeding. This is the non-specific drugs to control the bleeding. Okay, we will use widely in the clinical settings. So to control the bleeding, there is the tranexamic acid. Okay, so very important, keep in your mind, right? So but in the question what they have asked is, so there is the mechanical method. Means here we are not using the drugs, here we are not doing the surgery, just we are creating the pressure on the uterus. Okay, mechanically we are creating the pressure on the uterus to control the bleeding. Okay, so whenever the bleeding will happen on the head, what you will do, you will create a pressure. Like similarly in the uterus, the bleeding is happening, so you are creating the pressure here. Okay, in the mechanical method, what you are doing, you are creating the pressure here on the uterus. Remember, right? So option A is the uterine oxytocin infusion. So this will be comes under the medical management, beta. So this will be comes under the medical management. Just we have discussed this one. Okay, so then the uterine artery ligation. So this will be comes under the surgical management. So only one thing we have remained here, that is the Buckley balloon catheter. So that is the how we have to do the medical like mechanical methods. I will explain how the Buckley balloon catheter we can use in the management of the our PPH. Okay, so do remember what are the things we have to do in the PPH management. First thing is that is the bimanual uterine compression I will maintain. So what is the meaning of the bimanual? Bi means two. Okay, so bimanual means two sides we are creating the pressure, that is the manually by the hand. Okay, so look at this particular hand which is above the uterus. Okay, so that is per abdominally, one hand is above the uterus and another hand is inside the vaginal cavity, and so in the two direction, from here the pressure is coming and from the here is pressure is coming, and uterus I have compressed between two hands So that is what we call the bimanual uterine compression, so in order to reduce the risk of the bleeding. Okay, so very very important, just keep in your mind, right? So the next one is the Buckley balloon catheter. Okay, look at this particular catheter which is there in the inside the uterus. Okay, so this is what we call the Buckley balloon catheter. Just I have inserted the catheter inside the uterus, and with the syringe, okay, so we have infused the saline inside the uterus, so which we have been created the pressure inside the uterus. So that is the Buckley balloon catheter we can use in the control of the postpartum hemorrhage. Okay, so we can decrease by using the bimanual compression and by using the Buckley balloon catheter. Okay, so similarly, look at this particular. Okay, so this one, every one of you know the Sangastakan Blackmore tube, where we are using this one in the esophageal varices to control the esophageal bleeding. Okay, so this is the gastric balloon which will opens in the stomach, and this is the esophageal balloon which will opens in the esophagus. Okay, so did you heard about the Sangastakan Blackmore tube? Yes. Yes, do like thumbs up in the comment box. Did you heard about the Sangastakan Blackmore tube? Yes, usually we will use the Sangastakan Blackmore tube in the esophageal varices, right? Means the bleeding is happening from the esophagus. Okay, so in the esophageal varices, there is the superficial veins of the esophagus which are bleeding. In order to control the bleeding in the esophageal varices, we will use the Sangastakan Blackmore tube. Similarly, if the bleeding is happening from the uterus, same Sangastakan Blackmore tube we will insert inside the uterus, and the gastric balloon will be inflated inside the uterine cavity, and the esophageal balloon we will inflate inside the vaginal cavity. If the perineal tear bleeding is happening from the perineal tear, also will be get controlled, and the bleeding is happening from the uterine cavity also will be get controlled by the Sangastakan Blackmore tube. Okay, so the question will arise here. Okay, from the Sangastakan Blackmore tube or from the Buckley balloon catheter, and also we will use the condom catheter also. Similarly, we will inflate the condom catheter inside the uterus. Okay, so do remember the very very important thing, and the question will come from the Buckley balloon catheter. So what is the maximum capacity of the Buckley balloon catheter? That is the 500 ml of the maximum capacity it is having. Maximum capacity. So what to infuse inside the Buckley balloon catheter? So that is the normal saline. So whether cold or warm, sir? Yes, the warm normal saline we will infuse inside the Buckley balloon catheter. So maximum how much we can infuse? We can infuse the maximum up to 500. Yes, is that clear, beta? Every one of you, so to fatapat do mention your answer. Yes, well done, right? So here is the next management after mechanical management. So we have inserted the Buckley balloon catheter, bleeding not controlling. We have inserted the Sangastakan Blackmore tube, bleeding not controlled. I have created the pressure by using the both the hand, that is the bimanual compression of the uterus. Still the bleeding is not controlled. Okay, sir, what I can do the next management? Beta, after mechanical management fails, you can still the bleeding is happening means after mechanical management fails, still the bleeding is happening means you can go for the surgical management. Okay, so that if the family is completed, means I will remove the uterus. So that is what we call the hysterectomy. Hysterectomy means removal of the uterus, right? If the family is already completed, means the mother is having the 2 kids, 3 kids, she don't want to continue the next pregnancy. So in that situation, I will remove the uterus. Uterus is not there means there is no uterine bleeding. No uterine bleeding means no PPH. Okay, so very important, right? So if the family is not completed, so the mother, she came in the past, she is first time pregnant only. Okay, so she want to next time also she want to get pregnant. So in that situation, so just I will use the B-Lynch suture to create the pressure. Okay, so B-Lynch suture means how we have to use the B-Lynch suture like this. So do focus on the image. I am doing the suture like this here. Complete circles like suture I have created here. Okay, so in order to create the again pressure on the uterus, so this is what you call as the B-Lynch suture. Okay, this is what I call as the B-Lynch suture. So this will be your very very important image based questions. It may directly strike again in your exam. Okay, so that is B-Lynch suture will be applied on the uterus, that is used in the PPH to reduce the risk of the bleeding. Okay, so do remember the 2 important golden points along together with the image based question of the B-Lynch suture. Okay, yes sir, we have maintained the B-Lynch suture. So still the bleeding is not controlling. What I can do, sir? Sir, you have to still the bleeding is not controlling means, sir, we have to stop the blood supply to the uterus, sir. First, I will ligate the arteries which is supplying to the uterus. Okay, so just I will block the artery which is supplying to the uterus. Uterine artery and ovarian artery are the 2 arteries which will supply to the uterus. I will ligate those arteries, so bleeding will control. If still bleeding is not controlling means I will do the hysterectomy. There is no any option. Okay. So hope the entire management of the PPH is very much clear to every one of you, right? So hope it is clear, right? Here is the next question, and this is your very important question. Better from the PPH, you will definitely get one question in your exam because the concept was very important, right? So here is the next question. Which degree of the perineal tear is involves the anal sphincter complex but not the rectal mucosa? Yes, I'm waiting for your excellent and brilliant answer in the comment box. So please do response to the question what I'm showing here in front of you all. So which degree of the perineal tear involves the anal sphincter is breaked but the rectal mucosa is not involved? Okay, so that is the option A, first degree, option B, second degree, option C, third degree, and option D is the fourth degree. So please do mention your answer in the comment box. Which degree of the perineal tear involves the anal sphincter complex but not the rectal mucus? I want your everybody's answer in the comment box. So please do mention answer. Well done. So few of you only given the correct answer. That is the third degree. Third degree. So that is the third degree of the our case of perineal tear. Okay. So better degree of the perineal tear is very important concept. Just quickly within 2 to 3 minutes, I will revise all the degree of the perineal tear with image based explanation. So please do focus and please pay the special attention on the thing what I am explaining now. Look at this particular degree of the perineal tear in the grade 1. So total how many grades we have? 4 grades. Grade 1, 2, 3, 4. Okay. No, there is any grade 5. There is no any grade 6. In exams, there is chance of asking the mentioning the grade 4, 5 and 6 also. Don't go for that anything. Okay. So only we have the 4 grades of the perineal tear. The first one, if only the vaginal skin is broken and only vaginal mucosa is broken. So that is called as the grade 1 perineal tear. Only grade 1, in the grade 1, vaginal skin and vaginal mucus is broken. In the grade 2, vaginal skin is broken, vaginal mucus is broken. Along with that, the vaginal muscles also broken. In grade 1, 2 things broken. That is the skin and mucosa. In grade 2, 3 things broken. That is the skin, mucosa and muscle. In the grade 4, in the grade 3, 4 things broken. One is the skin is broken, mucus is broken, vaginal muscle is broken, along with the anal sphincter also involved. Okay, so that is the grade 3. In the grade 4, the 4 things are, in the grade 4, the total 5 things are broken. So there is the skin also broken, mucus also broken, and the muscles also broken, anal sphincter also broken. So there is the grade 3 plus rectal mucosa also broken. In the question what they have asked, there is anal, till the anal sphincter the tearing is there, but not the rectal mucosa. If this is including the rectal mucosa, answer will go for the 4th degree. So this is only a involvement of the anal sphincter. So that is the answer will goes to the our very important 3rd degree. But in the degree 1, vaginal mucosa and vaginal skin is broken. This is the anus which have been not broken. Okay, so not involved. In the grade 2, vaginal mucosa, vaginal skin and the perineal muscles also broken. That is what we call as the 2nd degree. Okay, so the next 3rd degree where the vaginal skin is broken, mucus is broken. Okay, so along with that the muscles also broken and till it involved the anal sphincter. So till it involved the anal sphincter, that is the 3rd degree. Okay, so look at the 4th degree. Vaginal skin broken, mucus broken, and the muscles broken, anal sphincter broken, and it went till the rectum. Okay, rectum is involved means that is the 4th degree. Okay, here the 1st degree and the 2nd degree. Okay, so 1st and 2nd degree, we call this one as the minor perineal tear. Okay, so these are called as the minor perineal tear. So this one, immediately after the labor in the OT table only we will repair the 1st degree and 2nd degree perineal tear. The 3rd degree and 4th degree perineal tear, so we call this one as in the complete perineal tear or the major perineal tear. So this particular both 3rd degree and 4th degree perineal tear, I will take the patient to the OT and I will give the general anesthesia and we need to repair this one. Okay, so in the OT we have to repair the 3rd degree and 4th degree, and in the like labor table only we can repair the first degree and second degree. Okay, so hope the concept is clear to every one of you. And the degree of the perineal tear is very important. So this is your very important, just a simple thing, just one time you have to revise. Okay, that is the more than enough, right? So if you want, you can take the screenshot of that one, right? So here is the next question. So what is the primary purpose of the performing the reduction maneuver during the childbirth? So last Norcet image based questions have been arised from the reduction maneuver. So before the exam also in the OBG maneuver classes, the complete explanation of the each and every maneuver with the concept clearance I have given. Okay, so in the OBG maneuvers, still the classes available in your YouTube. Okay, so you can watch those classes for the a better rank in the mains exam. Okay, so here's the what is the primary purpose of the performing the reduction maneuvers during the childbirth. Option A, to speed up the second stage of the labor. Option B, to reduce the maternal pain. And option C, to control the delivery of the fetal head and reduce the perineal trauma. And option D, to rotate the fetal head for the shoulder delivery. Better, the reduction maneuver is performed. The reduction maneuver is performed to control the head of the baby in a controlled manner we want to deliver, and we have to avoid the perineal trauma. So that is the main purpose of the reduction maneuver. Okay, so look at this image. So very important image. Okay, here the head of the fetus will be controllably we have to deliver. Okay, so how we have to deliver? So first we have to maintain the flexion and slowly we have to extend the head and we have to deliver. Better. So I told in the normal cephalic presentation, head of the baby will be delivered by the extension. Okay, in the like in the breech conditions, after coming head of the baby, we have to deliver by the method of the flexion. So here in the cephalic presentation, we are delivering the head. Okay, so how we have to deliver? First we have to maintain the flexion, then slowly we have to extend the baby. Slowly head of the baby will be extended, and the controlled head delivery we will do. Along with that, by other hand, at the perineal body and at the anal sphincter, I will give the support with a warm towel, so it will get relaxes the perineum and the head will comes easily outside. Okay, so this is what we call the reduction maneuver. Reduction maneuver. We will use this one in the prevention of the perineal tear. Okay, so we are using this one in the prevention of perineal tear. Okay, so hope it is clear to every one of you. Yes. So this will be an important question, right? So the next question is here in front of you all. So please do read the question carefully, completely, and try to give the best answer in the comment box. Yes. In vacuum assisted vaginal delivery, the ideal site of the vacuum cup application on the fetal head is. So what is the ideal site of the application of the vacuum cup in the vacuum assisted vaginal delivery? Yes. Option E, where we have to apply the vacuum cup, whether we have to apply on the bregma or on the lambda or on the anterior fontanelle, okay, or on the posterior fontanelle or at the middle of the anterior posterior fontanelle, where we have to attach that one. Beta, remember the anatomical landmark where we have to attach the very important vacuum cup is. So this is our anterior fontanelle and this is our posterior fontanelle. Okay, so from the anterior fontanelle, you have to come back, that is a 6 centimeter posterior to the anterior fontanelle you have to come, right? And from the posterior fontanelle you have to come 3 centimeter front. Okay, so that is the 3 centimeter you have to come, means it is 6 centimeter posterior to the anterior fontanelle and it is 3 centimeter anterior to the posterior fontanelle. So this is the anatomical landmark. This is the anatomical landmark where I will site of the application of the vacuum cup. Okay, so this is the site of the application of the vacuum cup in the instrumental delivery. Remember the very important thing. Okay, so comes to the question now and give the best answer in the comment box. Yes, where we have to attach, that is the over the sagittal suture. Yes, this is the middle one is the sagittal suture. Yes, on over the sagittal suture we are applying and 3 centimeter anterior to the posterior fontanelle. So this is the posterior fontanelle. Okay, so from here we came 3 centimeter anterior. Okay, so that is the area where we have to attach the vacuum cup. Okay, so from here anterior fontanelle we have to come 6 centimeter back, and from the posterior fontanelle we have to go the 3 centimeter anterior. Okay, so that is the anatomical landmark where we have to attach the vacuum cup. Okay, so that is the very important thing. And also remember the golden points. Okay, on the vacuum cup. Okay, so here the initial pressure watch which is creating here is the only 0.2 kg per centimeter of pressure will be created initially, and the maximum pressure it will get creates is the there is our 0.8 kg per centimeter it will creates. For this creation of this particular pressure, it will take at least near about the 5 to 10 minutes. So that is the reason this vacuum cup is not useful in fetal distress. Okay, if the fetus is in the distress condition, we can't wait for the duration of the 5 to 10 minutes. So that is the reason the vacuum cup is not used in the fetal distress condition. So in case of the fetal distress, we will go for the forceps delivery. Okay, so we will not wait for the vacuum to get pressure, get to create the pressure, and we can't wait for the duration of the 5 to 10 minutes because the fetal is in the state of the distress and the fetal may get land into the death also. Okay, that is the reason we will not wait for the duration of the 5 to 10 minutes. Just I will go for the forceps delivery if the vacuum is if the fetus is in the distressed condition. Okay, hope the concept is clear on this one. Yes, so every one of you know when we have to apply the vacuum or the forceps, if the fetal head is +2 station or below the +2 station, then only we can go for the instrumental delivery. If the fetal head is above the +2 station, so we can't go for the instrumental delivery. So that is we can go for the LSCS. Okay, so very important concept on the vacuum delivery. And here one more question which is there in front of you. So please do read the question carefully, completely, and try to give the best answer in the comment box. Okay, so what is the chignon in context of the vacuum assisted vaginal delivery? What is the mean by the chignon in context of the vacuum assisted vaginal delivery? Yes. Option A, type of the fetal skull fracture. Option B is the blood-filled swelling beneath the peritoneum. Beta, if the blood is collected beneath the peritoneum, so that is a cephalohematoma. Okay, which is not a chignon, right? Then the option C, a temporary swelling on the fetal scalp at the site of the vacuum cup application. Beta, I told this is the site of the vacuum cup application. So in this particular site of the vacuum cup application, due to the pressure which we have created during the instrumental delivery by the vacuum cup, so there will be accumulation of the some fluid. Okay, so there is accumulation of the some fluid and there is a chance of the swelling at the site of the vacuum cup. Okay, so that is what we call the chignon. What is the chignon? At the site of the vacuum cup application, there is a minimal swelling and the accumulation of the fluid. So that is what we call as in the chignon. Okay, so chignon is, yes, so there is a temporary swelling on the fetal skull, on the fetal scalp. Okay, so that is at the site of the vacuum cup application. So that is what you call the chignon. It is your very important question, right? So hope it is clear to every one of you, and do identify this particular new image. Okay, so very important IBQ. Don't confuse if it comes in the exam, sir. What is this? What is this? What is this? Yes, what is this? This is the ominous cuff. So this is the new image. Okay, so we can use this one time and we can discard this particular ominous cup because this is on the one time using cup. So we are using this one to create the vacuum and to deliver the head of the baby. Okay, so this is also in the vacuum assisted delivery. Okay, so very importantly, this is the new one. Okay, in the many hospital they are using because it is on the one time usable. Okay, so hope it is clear to every one of you. Here we have to apply the ominous cup directly on the scalp of the baby and we can pull this one. Okay, so we can create pressure by using this particular machine and the pressure is created, so we can pull this one out. Okay, so this is the ominous cup. So this will be asked in your exam directly, so do remember this a very important new vacuum device. Okay, so hope it is clear. And here is the next question. Yes, the question is very simple and the question is on the Bishop score. Okay, so question is on the Bishop score. So please do read the question completely and try to give the best answer. Yes, a 32-year-old woman, she is gravid to parity 1 at the 41 week of the gestation. She is at the 41 week of the gestation, means already she is at the late third trimester, we can say. Okay, and she presents for the labor induction. Okay, so she came to the hospital for the induction of the labor. Okay, on the vaginal examination, findings shows the following: cervix is dilated 2 centimeter, effacement is 15%, and the station is -2, and the cervical consistency is medium. So cervical position is the posterior, right? So what is the correct answer? And what is the likelihood of the successful of the induction of labor in this particular situation? So do remember this particular Bishop score here, beta. This is the Bishop score. Take a screenshot of this one. At least revise 1 to 2 times. So this is the old Bishop score. Still in the clinical setting, we are using this one only. Okay. So after that, there is one more Bishop score have come. That is the modified Bishop score. In that particular, so this cervical effacement they will not consider. Okay. Instead of this cervical effacement, so they have replaced this one with the cervical length. Okay. So length of the cervix they have told in the modified Bishop score. But still in the hospital settings, they are using the Bishop score only. So there is chance of asking the question from the Bishop score only. Okay. In the question they have mentioning the length means you have go for the modified Bishop score. In the question they have mentioned for the effacement for the in the question they have mentioned like effacement only means you go for the old Bishop score only. Okay. So here we have the component of the Bishop score like this. Okay. So that is to remember, that is the Delhi police employed special captains, or we can say special commanders also we can say. Okay, so here is the D stands here means a dilation of the cervix. Okay, D stands means here the dilation of the cervix. P stands here the it is in the position of the cervix, and E stands here the effacement of the cervix, effacement of cervix. S stands here the that is on the S stands. What is the S stands here that is the station of the fetal head. Okay, so that is the station of fetal head, and the C stands here is the consistency of the cervix. How the cervix is there? Is that a firm, or is that a medium, or is this a soft cervix? Okay, so based on these points, we have the 5 components. One is the, I told Delhi, there is the dilation of cervix, and the police, that is the position of the cervix. Okay, and employed, that is the effacement of the cervix. Okay, so then the special, that is the station of the cervix, and the commander or the captain, that is the consistency of the cervix. Okay, so here in our question, what happened here? The cervical dilation is 2 centimeter, effacement is 50%, station is -2, and the cervical consistency is medium, and the cervical position is the posterior. So what is the score is that one? So don't do this one as the medium. So consider this one as in the cervical consistency as firm. Okay, so this is the firm. So now calculate the Bishop score. Yes, so comes to the Bishop score here. Cervical dilation, how much it happened? It happened at 2 centimeters. Means I am giving the 1 point. Then the effacement happened the 50%. Again, I will give the 1 point. Right? So then the fetal station is -2. Again, I will give the 1 point. Okay. So then cervical consistency is firm. So I will give the 0. Okay. And okay, so no problem. You consider this one as the medium only. Okay, so no problem. You consider that one is the medium only. Okay, so medium. So 1 I have given, right? So then the cervical position is the posterior. So I am giving the this one is 0. So total how many score? 1, 2, 3, 4 score. Okay, so total 4 score. Okay, total score are the 4 here, and the score is 4 means cervix is not still ready for the induction of the labor. Beta. So when we will use the Bishop score is used before the induction of the labor. Why, sir? Why? Because to assess whether the cervix is ready for the induction of labor or not. If the cervix is not ready for the induction of the labor, we will not induce the labor. If the cervix is not effaced, if the cervix is not dilated, so how can we will induce the labor? It is very difficult to induce the labor. Okay, so check the cervical readiness for the induction of the labor. We will use the Bishop score. Sir, many times asked the golden point, sir. Don't forget. So that is the why we are using the Bishop score. Bishop score is using before the induction of the labor for the assessing the readiness of the cervix to induce the labor, or to assessing the preparation of the cervix to induce the labor. Okay, so before induction of the labor we will assess the cervical consistency, dilation, effacement, everything. So the position and the everything regarding the cervix we will assess. If the cervix is ready, we will induce the labor. If the cervix is not ready, we will not induce the labor. So when we will say the cervix is ready, when we will say the cervix is ready, cervix is ready if the Bishop score is coming more than 8 or more than 9. If the more than or equal to 8 or 9, if it is coming means, so cervix is ready, we can induce the labor. If the Bishop score which is coming less than 6, so that is the still it is the cervix is not ready, so we can't induce the labor. Okay, so very very important, keep in your mind. So maximum score of the Bishop score is the 13. Okay, so that is the 13 is the maximum score of the Bishop score. Okay, so do remember the very very important point regarding the Bishop score. Okay, so hope now the clear. Okay, so score is 4, so less than 8 means, so that is the cervix is unfavorable, means cervix is still not ready, and cervical ripening still required. Okay, it is not completely ready, so still the cervical ripening is required. Answer A goes to the correct answer. So this kind of the scenario based question, or the question at least from the this particular Bishop score, it will be struck in your exam. So please do remember the Bishop score and the mnemonic to remember the Bishop score, and the interpretation of the Bishop score, which is very important for you all. Okay, so here is the next question which is in front of you all. Okay, so please do read the question carefully, completely, then try to give the best answer for this question, and it is also very very important question. So this is very very again very important question. What is the next best step of the management? The scenario based practical based question is in front of you all. So please do read the question carefully and give the best example, best answer in the comment box. Yes, what happened here? A 28-year-old primigravida at the 40 week of the gestation. So she is undergoing the induction of the labor with oxytocin, right? So already she is 28-year-old primigravida and she is a 40 week of the gestation, and she is undergoing the induction of the labor with the oxytocin. Okay, so with the oxytocin we have administered and we have induced the labor. So we have checked the Bishop score, cervix is ready, so cervix is completely ready for the induction of the labor, means the Bishop score is coming more than 8 or 9, so we have induced the labor. Okay, with the oxytocin. Now after starting the oxytocin, okay, after several hours, what happened? The nurse is noting that there are more than 5 uterine contraction in the 10 minutes. Beta, I told what is the normal uterine contraction. So that is the 3 to 4 uterine contraction should happen for the 10 minutes. So that is for the duration of the 45 seconds each contraction. Okay, and the pressure will be like 65 to 75 mm of Hg should be the pressure. Okay, so this is the intensity and this is the duration, and this one is the very important rate of the uterine contraction. If uterine contraction is happening more than 5 per 10 minutes, I call this one as the uterine tachysystole. Okay, so if the uterine contraction happening more than 5 per 10 minutes, so this is the uterine tachysystole. Along with this, the fetal distress is also happening. So I will call this one as the uterine hyperstimulation. Okay, hope the two things are clear. Uterine tachysystole means uterine contraction happening more than 5 uterine contraction for the 10 minutes, and if along with that the fetus is undergoing the distress, means that is the uterine hyperstimulation. Okay, so each lasting for the 19 seconds. So better normal duration I told it is 45 seconds, but the each contraction which is lasting more than 19 seconds. So again it is the case of the uterine tachysystole and the uterine hyperstimulation and the hypertonic contraction of the uterus. Okay, so uterus feels hypertonic on the palpation. So what is the next best step of the management? Yes, option A, increases the uterine infusion rate. But already oxytocin is increasing the uterine contraction. So again you are increasing the oxytocin infusion rate, means again the rate of the contraction, duration of the contraction will increases. Only contraction will happen means the blood supply to the fetus will stop. The fetus will get the distressed hypoxia and the fetal death may also happens. Okay, so the first immediate next step of the management is the stop the oxytocin and infuse the stop the oxytocin, and like immediately we need to stop the oxytocin. Okay, so that is a very important management step we have to keep in your mind, right? So the next important golden point revision here is, so that is whenever there in the tachysystole happens, uterine tachysystole happens. So in this particular situation, first step is to stop the oxytocin. Better in the option you will get to reduce the rate of the oxytocin and to stop the oxytocin. So which one you have to choose? Don't go for the reduce the rate of the oxytocin. Directly you have to stop the oxytocin. Then after stopping the oxytocin, this is the first step of the management is to stop the oxytocin. Then they keep the patient in the left lateral position. Then start the oxygen. So that is at the liter of the 6 to 10 liter per minute via a face mask. And after that we can inform the primary health care provider. Okay, so this is the very important, just keep in your mind. Okay, so the tachysystole means that like contraction will be more than 5 contraction for the 10 minutes and the duration will be more than 45 seconds. Okay, and intensity which increases in the pressure also. Okay, so this is what we call the uterine tachysystole. Along with this, if the fetal distress is happening, we call that one as the uterine hyperstimulation. Okay, so that is what we call as the uterine hyperstimulation. Hope it is clear to every one of you. Yes, so the next like management I have told you very clearly, it is important to every one of you, right? The next question is here in front of you all, so please do read the question completely carefully, then try to give the best answer for this particular question here. What is the Robert sign in relation to the intrauterine fetal death? What is the meaning of the Robert sign in relation to the intrauterine fetal death? Option A, the overlapping of the fetal skull bones. Okay, option B, absence of the fetal heart motion on ultrasound. There is no fetal heart motion on the ultrasound, it is saying. And option C, presence of the gas in the great vessels of the heart and the fetus great vessels and in the heart. So there is the presence of the gas is there. And option D, decreased amniotic fluid volume. Which one is the correct answer? Yes, well done, better. So a few of you have given the correct answer. That is the Robert sign is the presence of the gas in the great vessels of the fetus. Okay, so when the fetus will die inside the mother uterine cavity, so that is what we call as the intrauterine fetal death. Means after the period of the viability, after the 28th week of the gestation, fetus is getting died in the inside the uterus. Means so that is what we call the intrauterine fetal death. So in this particular situation, the first sign, the earliest sign, so that is our Robert sign. Okay, so the Robert sign is the first sign and the earliest sign on the X-ray. Okay, on the X-ray, so where we can easily see the gas which have been accumulated inside the great vessels and the heart of the uterus. So that is what heart of the fetus. So that is what you call as the Robert sign. Okay, so let's quickly revise all the golden points on the intrauterine fetal death signs. Okay, so here is the Robert sign. Robert sign is the I told. So this is the presence of the gas in the great vessels of the fetus. Okay, like aorta, inferior vena cava, superior vena cava, and in the heart also. Okay, so this will happens within 12 hours. Okay, so within 12 hours after the fetal death, the Robert sign will happens, and this is the earliest sign. Okay, so this is the early sign of fetal death in X-ray is the our Robert sign. Okay, so do remember this particular very important point. Okay, so the next one is here. So that is the Spalding sign. So what happens in the Spalding sign? So overlapping of the cranial bones of the fetus will happens. So this overlapping of the cranial bones of the fetus will happens. Along with that, the brain will get liquefy. Okay, so brain tissue will get liquefaction. Okay, so brain tissue liquefaction due to the overlapping of the fetal skull bones. So that is what you call as the Spalding sign. So Spalding sign is the overlapping of the fetal cranial skull bones along with the brain tissue liquefaction. So this is what you call the Spalding sign. Okay, so this one will be seen after the 7 days after the fetal death. Okay, so this will be seen after the 7 days after the fetal death. So that is what you call as the Spalding sign. It is the very important thing. Just you have to keep in your mind, right? So here is the next sign which we will see in case of the intrauterine fetal death. That's the ball sign. Okay, so where in the dead fetus it will completely hyperflexion or it will get completely hyperextension and it will looks like a round structure. So that is what we call the ball sign. Okay, so which will due to the hyperflexion or due to the hyperextension of the fetal spine. So the fetus inside the mother abdomen which looks like a round or the ball structure. So this is what we call as the a ball sign, and it will be seen around 3 to 4 weeks after the intrauterine fetal death. So this will be the late sign on the X-ray. Okay, so late sign on the X-ray is the ball sign. Early sign on the X-ray is the our Robert sign. Okay, so hope it is clear to everyone of you, right? So here is the next question. So please do read the question carefully, completely, then try to give the best answer. Which of the following best describes the physiological puerperium? Option A, puerperium complicated by the infection. So that is the puerperial pyrexia we can say. Okay, or the puerperal sepsis we can say. So that is the not physiological one. Okay, so I'm eliminating the option A. So then the option B, normal recovery phase after the childbirth within the 6 weeks. Yes, the puerperium period will be after the childbirth and within the 6 weeks. Okay, so here all the recovery will start. Means the uterus which increased height will be get decreased and which comes to the normal. Okay, so the cervical changes which happened during the pregnancy which comes to the normal. Okay, so along with that the endometrial changes which happened during the pregnancy which comes to the normal. Okay, so and along with that all the genital and the non-genital whatever the things happen means, so the weight gained during the pregnancy which will comes to the normal, everything which changed during the pregnancy which comes to the normal. So that is what we call the puerperium period. Okay, so puerperium period will be our 6 week. Okay, so within the 6 week all the changes which happen during the pregnancy which will comes to the normal. So that is what we call the puerperium period which is normal. Okay, so hope it is clear to every one of you. Then the puerperium extended behind the 6 week means 6 week have been fast, still the all things which have been not come to the normal. Okay, so that is what we call the delayed puerperium. Okay, so that is what we call the delayed puerperium. Remember, then the puerperium after abortion, so this is will not happens that much great. Okay, so it's not a physiological puerperium. Okay, so the correct answer for this question goes to the normal recovery phase after the childbirth within the 6 week. So this will be our puerperium normal physiological function. Okay, hope it is clear to every one of you, right? So in the puerperium we have the 3 types of the puerperium. So this is your very important and your last RRB exam question. Okay, so this is the very important. So this can again strike in the Norcet exam also. The types of the puerperium. So that is the immediate puerperium, early puerperium, late puerperium. Beta, you people will confuse like it is mild, moderate, severe, or the first degree, second degree, third degree, or it is on the early, middle, late. It is not like that. It is immediate, early, and late. Remember, immediate, early, and late. It is not an early, middle, and late. It is on the immediate, it is early, and it is late, right? So you have to keep in your mind. The first one is the immediate puerperium. Immediate puerperium will be within 24 hours after the delivery. We will call that one as the immediate puerperium. Early puerperium is the puerperium which is after 24 hours and within 1 week. So that is what we call as the early puerperium. And the late puerperium is the after 1 week till the 6th week. We call that one as the late puerperium. And the puerperium will complete by the 6th week. Yes, please do repeat with me. Which one we call is the early puerperium? Early puerperium is the after 24 hours and within 1 week. After 24 hours, within 1 week is the early puerperium. Within 24 hours after birth is the immediate. And 1 week to the 6th week is the late puerperium. Okay. So in the exam, what we will get confused, they will give the early, middle, and late options. So you will get land into confusion. So don't confuse. We have studied which mistake also we will do and we are recovered from that one. Okay, so don't be land in the confusion. Okay, so within 24 hours after the delivery, that is the immediate. 24 hours to the 1 week, that is the early, and after the 1 week till the 6th week, that is the late puerperium. Okay, so that is the types of the puerperium as your golden points I have revised here. Okay, so next is here. The next question is here in front of you. Yes, so fatapat do mention your comment answer in the comment box. So by the end of the first week postpartum, the uterus weight is approximately how much? Yes, the uterus weight during the pregnancy which have been increased till the 1 kg or the 1000 grams, right? So during the pregnancy weight of the uterus is the 1000 grams. After the delivery, at the end of the first week, we are not asking the question at the end of the 6th week. So within 1 week after the delivery, how much is the weight of our uterus? Here, okay. Option A 300 gram, option B yes 100 gram, option B C is the 60 gram, and option D is the 500 gram. Better. So correct answer for this question goes to the 500 gram. Okay. Okay, so correct answer for this question goes to the 500 gram. And here are the very important thing. Just try to remember, within 1 week from the 1000 gram it will comes to the 500 gram. Okay, at the end of the second week it will comes to the 300 gram. At the 3 to 5 week it will comes to the 150 gram, and at the 6th week it will comes to the 60 to 80 gram. Okay, 60 gram is the a very important weight of the non-pregnant uterus. Means within the 6th week it is coming back to the normal. Okay, so within 6th week it is coming back to the normal till the 60 grams. So that is the weight of the non-pregnant woman. So the all the thing which is reversing back to the non-pregnant woman state. So that is what you call as the yes, involution of the uterus. Okay, so uterus what have been changed in the height, whatever what have been changed in the weight. So everything which will comes to the pre-pregnant state within the 6th week. That is what we call the involution of the uterus. Okay, what is the involution of the uterus? Involution of the uterus is yes, the uterine weight, height, and other changes will come back to normal pre-pregnancy state. Okay, so before pregnancy how much it was, so to that particular stage it will comes. Okay, so that is the it will come back to the pre-pregnancy state. So this is what you call as in the involution of the uterus. Okay, hope it is clear to every one of you. Yes, uterine weight, height, and other changes which will come back to the normal pre-pregnancy stage. So that is the involution of the uterus. If it comes within 6 week, we will call this one as the involution of the uterus. If 6 week have been passed and still the uterus it is not coming back to the like it is not coming back to the its normal position, so that is what you call the sub involution of the uterus. Means so it is 6 week passed and it have not came to the pre-pregnancy state. It have not came to the pre-pregnancy state. So this is what we call as the sub-involution of the uterus. Okay, this is what we call as in the sub-involution of the uterus. So that is the 6 week have been passed and it have not came to the pre-pregnancy state. So that is the involution of the uterus have been not came. Okay, involution of the uterus have been not happened. So that is what we call the sub-involution of the uterus. So it happens due to the infection inside the uterus, or it happens due to the placental tissue retention. Means the placental tissue still inside the uterus only. Okay, so it happens due to the placental tissue retention. Okay, so very important, keep in your mind. Okay, so immediately after the delivery where the uterus will be located. Yes, immediately after the delivery where the uterus will be located, it is present at the level of the umbilicus, or we can say it is present at the level like at the 12 week of the pregnancy. It is at the level of the umbilicus. Okay, just 1 second please. Right, so or we can say it is 13 centimeter above the symphysis pubis, we can say. Okay, so that is the height of the uterus. Okay, height of the uterus every day it will reduces for 1 day 1.2 centimeter height will get reduces, and within 12 to 13 days the height of the uterus will comes back to its normal height. Okay, so that is what we call as in the involution of the uterus. Okay, so very important. And the question and all the golden points related to the uterine changes we have finished here. Okay, so that's the very important thing for you all, right? So here is the next question, and this is also a very important question for your upcoming exam. So please do read the question carefully and try to give the best answer. Which of the following is the common risk factor for uterine prolapse? Option A, multiparity. Option B, menarche before the 12 year of the age. And option C, use of the oral contraceptive pills and the cesarean delivery. So which is the common risk factor for the uterine prolapse? Beta, uterus is coming out of the vaginal cavity. So that is what you call the uterine prolapse. So why it will comes? It will comes when the support of the uterus will decreases. Okay, it will comes when the support of uterus decreases. When the support of the uterus will get decreases, when the perineal muscles weakness happens. Okay, when the perineal muscles weakness happens, in this particular situation, there is a chance of the uterine prolapse will be there. Okay, so it happens means the support of the uterus will get decreases when the mother will go into the repeated vaginal delivery. The strength of the perineal muscle will get decreases. Okay, so the multiparity is the most common risk factor which will associated with the uterine prolapse. Okay, so do remember, and the grade of the uterine prolapse is the very important table. Okay, so very important table for your exam, right? So grades of the uterine prolapse. So grade 0 is that is the normal, nothing have been happened, so there is no any prolapse. Okay, uterus is still which is in its anatomical position and it have been not changed, so that is the grade 0. So grade 0 stands here there is no any uterine prolapse. In the grade 1 what happens, the cervix descends into the upper part of the vagina, but it does not reach the introitus or the vaginal opening. Okay, so look at this image. So this is the first one is the normal. Okay, so this is the normal, here is our vagina, this one. So this is the vagina, right? So here is the uterus in its anatomical position, so that is the grade 0 or the normal one, right? In the grade 1 or in the first grade, what happened, this particular uterus, here is the vagina, so uterus came into the upper uterine segment. This is the vaginal opening, but it have been not came to the introitus or it have been not came till the vaginal opening. So this is the grade 1. In grade 1 what happens, just the uterus will comes into the upper part of the vagina, uterus will not comes out of the vagina. Okay, so that is the first degree, right? In the second degree what happens, the uterus came inside the vagina and it have came till the introitus or it have been came till the vaginal opening, but it does not cross and it went out of the vaginal opening. So that is what you call as the second degree. Okay, so in the second degree what happened, the cervix descends in the introitus, means it have been came in the vaginal opening, but uterus does not protrude outside. Uterus is not went outside of the body, it have still not went. Okay, so that is the grade second. Okay, in the grade 3 what happened, in the grade 3, look at the image, uterus came out of the, this is the vaginal opening and this much of the uterus have been came out of the what we can say, it have been came out of the vaginal opening, but still some part of the uterus is inside the vagina. So that is the third degree. Okay, in the third degree what happens, remember the cervix protrude outside the vaginal opening, but part of the uterus still within the vagina. So that is the grade 3. So grade 4 one is the, or we can say grade 4 is the procedensial uterus. Here the entire uterus including the cervix, fundus, everything is protruded outside. Okay, and the vaginal it have been crossed vaginal introitus, and this is called as the complete uterine prolapse. Okay, so this will what we call it, this one is the fourth one is the procedentia or the fourth degree or the complete uterine prolapse. Okay, so this is the vaginal, this is the vagina and this is the vaginal opening and everything, so including the fundus, cervix, everything, uterine bodies completely came out of the vaginal opening. That is what we call the procedentia or the fourth degree of the cervical prolapse, uterine prolapse. So this uterine prolapse is the very important for your upcoming exams. Okay, so please do remember this table because it is important to every one of you, right? Sir, what we can do as a management of this particular uterine prolapse, sir? So we we can't do anything for the till 6 week after the pregnancy, because till 6 week the uterus will go it's back to its normal position. Okay, like the height, weight, consistency of the uterus will returning to the normal position. After the 6 week we will do the surgery. Okay, after 6 week we will do the surgery. Okay, so where we will reposition the uterus or we will do the hysterectomy. Okay, so the very important thing. Okay, so till the 6 week what we have to do, sir? Okay, so that is the temporary management. We will use the ring pressure. Okay, so we will use the ring pressure till the 6 week. Okay, so after 6 week we will do the definitive management of this particular uterine prolapse. Okay, I hope it is clear to every one of you. And here is the next question. So please do read the question carefully, completely, and try to give the best answer for this particular question here. Yes. Which of the following is the correct sequence of the Lochia types and after the delivery? What is the correct sequence of the Lochia? So remember better, Russia. To remember the Lochia, you remember the Russia. Okay, in the Russia, what happened? The RU came first, so that is the rubra is the first. After that, double S, that is the serosa. After that, last A, so that is the alba. Okay, so rubra serosa alba. Okay, so there is the rubra serosa alba is the sequence of the our secretion which comes out of the vagina after the delivery. Okay, so what is the lochia? Lochia is the normal physiological secretion. Okay, it is not any pathological, it is not any disease condition. Okay, so this is the normal and this is the physiological, and it comes to the all the pregnant women after the delivery. Okay, so that is what you call the secretion which comes out of the vagina after the delivery. So that is what you call the lochia. And lochia, first it will comes red, then it will comes yellow, then it will comes white. Okay, so the red one is the rubra, yellow one is the serosa, white one is the alba. Okay, so here is the a golden point and quick revision of the types of the lochia. Better whatever the duration I have mentioned here, so this is according to the all updated new guidelines. Okay, so in the old guidelines this alba will be like till the 21 days. Okay, so but the new guidelines says it will be till 15 days only. Okay, so please do remember this chart only. Okay, so type of the lochia, here the lochia rubra, which is the red in color or the bright red, and which having the blood. Okay, so what will comes out of, okay, blood will come out, blood product will come out. Okay, so I'm sorry, blood will come out and product of conception will comes out in the lochia. Okay, so lochia rubra. Then in the lochia serosa, it will be like till 5 days to the 10 days. Okay, it will be yellow in color, and here the pus cells will comes out, right? So then the lochia alba, where the like 10 to 15 days, okay, where which is white in color, and the epithelial cells will comes out here. Okay, so this is the types of the lochia. Remember the types of the lochia by the Russia. Okay, so here by the Russia, that is the rubra, serosa and alba. Okay, hope it is clear, and the table also very much clear to every one of you. Okay, so here is the next important question. Which hormone is responsible for the stimulating uterine contraction and that causes the after pain? Beta, so what is the after pain? In the postpartum period or in the puerperium period, what happened? Due to the release of the oxytocin, the uterus will get contract. That time, after the delivery, in the postpartum or during the puerperium, the uterus is getting contract, and that will causes the mild lower abdominal spasmodic colicky pain. So that is what you call the after pain. So that after pain which happens due to the which hormone? Option A estrogen, option B progesterone, option C prolactin, and option D oxytocin. Yes, this happens due to the oxytocin. Better whenever the baby means after the delivery, means after the delivery means in the puerperal period, the baby will start to breastfeed. Okay, so when the baby will start to breastfeed, okay, when the baby will suck the breast, that time the oxytocin will release. So that oxytocin, it will act on the breast cell. Okay, and it will like helps to eject the milk outside the breast. Okay, along with that, that oxytocin which will act on the uterus also, and the uterus contraction will happen. So that time, due to the uterine contraction, there is on the lower abdomen, like colicky spasmodic pain will happen in the mother. So that is what we call the after pain. Okay, so that is what we call after pain. So that after pain which happens due to the oxytocin. Okay, so very important, right? So here is the next question in front of you all. So please do read the question carefully, completely, and try to give the best answer for this particular question here. So what is the mechanism of action of the cabergoline in the hyperprolactemia? So what is the mechanism of action of the cabergoline in the hyperprolactemia? Option A, it stimulates the prolactin production. Option B, it inhibits the dopamine receptors. Option C, it stimulates the dopamine receptors to inhibit the prolactin hormone. Option D, it inhibits the thyroid hormone release. So in the hyperprolactemia, there is increased prolactin, means there is excessive secretion of the milk. The hormone which is responsible for the production of the milk is the prolactin. So that is what we call as galactopoiesis. Poiesis, prolactin production. Okay, so very important. Remember, the galactokinesis means the milk is moving here, so milk is ejecting here. Okay, so ejection of the milk happens due to the oxytocin hormone. Okay, so remember, here we are using the cabergoline in the hyperprolactemia, means the excessive prolactin is there, so which is producing excess milk. Consider now she is a mother and she has the delivery. Now she have the baby, and which is it is dead. But still in the mother there will be a prolactin release will be there, and the breast milk production will be there, so which will cause the very much pain in the breast of the mother. Okay, so in order to reduce the hyperprolactemia condition in the dead baby situation, okay, in the mother we want to reduce the prolactin. So in that particular situation, the drug of choice I am giving is the cabergoline. Okay, so along with it, one more drug we are having to reduce the prolactin, that is the bromocriptine. Okay, Bromocriptine and cabergoline. But the bromocriptine, which is having the side effect of the like all the blood vessels, it will causes the vasoconstriction and it will cause to increases the blood pressure. Okay, so that is the reason we will avoid this particular bromocriptine, and the drug of choice is the cabergoline. Okay, it will stimulates the dopamine receptor and it will inhibits the prolactin secretion. So that is the mechanism of action of the cabergoline. Okay, so that is a very very important, keep in your mind. And if the baby is born still, so just you have to keep on a very important point in your mind. So if you want to produce the more milk, means you have to reduce the dopamine function. Okay, so where the dopamine is decreased, so there the prolactin will increases. There the prolactin will increases. Okay, so wherever the dopamine will increases, that time the prolactin will decreases. Remember, so here already hyperprolactemia means I want to increase the dopamine. So I'm dopamine increasing means prolactin decreasing. Prolactin decreasing means the hyperprolactemia I am treating here. Okay, similarly here cabergoline, which is stimulating the dopamine receptor and which inhibiting the prolactin secretion. Okay, so hope it is clear to every one of you. Yes, is that clear to every one of you? Stimulates the dopamine and receptors, and inhibit the prolactin secretion. Okay, so if you want to increase the amount of the breast milk production, so that time I will give the dopamine agonist drugs like metoclopramide is the drug of choice we will give to increase the production of the milk. Okay, so if you want to increase the production of the milk, you give the dopaminergic drugs. So that is the anti-dopaminergic drugs. So where the dopamine I am decreasing means the prolactin I am increasing. Okay, so anti-dopamine drugs we will give. Yes, anti-dopamine drugs. So that is the metoclopramide is the drug of choice I will use to increase the breast milk production. Okay, so if the mother she have given the birth to the baby and the baby is not getting sufficient milk, that time we will give the medication, that is what we call as the metoclopramide. So this metoclopramide is the drug which is having the ability to to decrease the dopamine, and the dopamine is decreasing means the prolactin will increases. Prolactin will increases means production of the milk will increases. Okay, so these are the very important questions we have discussed in the today's session. Okay, so like few more questions which are remaining here. Okay, that one I will discuss in the our Telegram group directly with complete explanation I will give there. Okay, so due to the overtime of this particular class, I will wind up it here. Okay, so again we will meet in the tomorrow session with a different subject, with a different practical based, NCLEX based, scenario based questions. Okay, so students, daily morning between the 8 to 10 a.m. I am posting one class in the Telegram channel and in the WhatsApp channel. Those questions are the practical questions, those questions are the scenario based questions, those questions which will mostly and maximum strike in your prelims exam. Especially for the clearing the prelims exams, must and should watch those classes what I am sharing in your particular WhatsApp group. Okay, so please don't forget that particular classes. Okay, so if you have still not watched, to watch that one. If you have already watched and that you have took the notes, so no need to watch again. So please revise your notes only. Okay, so this is the clear guidance from my side. And if any one of you are searching for the good test series for the upcoming Norcet exam preparation, and if you want to practice the real-time exams, so please go for our Super 60 test series. The link of the Master Nursing Classes app I have given in the description box. And for the more question discussion and the important remaining question discussion, please do join our Telegram group. Link I have given in the description box. And do join our WhatsApp channel also for the daily class updates and the daily class timings and any updates which is there in our nursing profession with the complete explanation you will get in our WhatsApp channel from the authenticate and standard source. Okay, so hope you have enjoyed the today's session. We will meet again with the tomorrow session. So that is a very important questions concept from the medical surgical nursing. Okay, so they are also in the short period I will cover the huge syllabus. Definitely I will maximum strike in your prelims and mains exam. Okay, so you will feel my face in the exams. So this is my promise from my side. Okay, so stay connected, stay motivated, keep preparing. No one can stop you to get selected in the upcoming Norcet exam. This is the your time. Just you have to prove it, just you have to work on it, just you have to show what is the potentiality what you have inside. Okay, so that is the, because this is the your time and this opportunity is created specially for you. Yes, beta. Yes, for you only this opportunity is created, and you have to prove in this particular situation who you are, why you are, and why you are existing in the nursing field, and what you can do. Everything you can show by this one single opportunity. So please claim it, don't miss it. Okay, and don't forget to join the Super 6 test series for the real-time practice and the important question practice. Thank you so much for watching the video till the end. Okay, so if you still not like the video and subscribe to the channel. We will meet again in the tomorrow session. Tab tak ke liye, Jai Hind, Jai Bharat. Love you all. Take care. Bye bye.